The neurological assessment, although it can be seen as a basic clinical skill, underpin many significant clinical decisions a healthcare professional can make. Determining mental competence of patients, highlighting clinically pertinent neurological disturbances, and defining a patient's level of consciousness are all assisted with those skills used within neurological assessments. Observations based on such exams are vital for healthcare professionals, supporting for or against patient self-agency, emergency examination authorities, and determining whether any neurological deficits pose risk to patient health. The standards of neurological examination are even more applicable to industries such as the mining sector. Queensland and other states in Australia, employees are responsible to follow the Occupational Health and Safety Act, ensuring workers are not risking themselves or others at the workplace, and to ensure safe systems of work. More specifically, according to the Coal Mining Safety and Health Regulation 2017, a coal mine safety and health management system must provide multifaceted care including risk identification and assessment, hazard analysis, hazard management and control, and lastly reporting and recording relevant safety and health information and data. Hence, elected healthcare representatives, you, have a duty to not only monitor health standards of employees, but ensure workers are relatively fit and not endangering themselves or others. The mining sector population presents unique health challenges with its distinct differences of fly-in, fly-out and rural lifestyles. Firstly, according to Roche and PID 2010, 12% of the mining industry workforce engage in illicit drug use, as well as a higher than average rate of short-term risky drinking, with 21.9% drinking high levels of alcohol at least monthly. Workers mostly represent males who are isolated, work irregular, long hours, and often don't have enough access to local healthcare. Such conditions then lead to fatigue, loss of sleep, bad diets, poor mental health due to isolation, and frequent depression. Therefore, such medical assessments should delve deeper into this subgroup rather than the atypical patient. At the start of the examination, it is important to ask for consent, perform with cultural sensitivity, and respecting patient privacy. Health professionals should begin with asking basic, baseline questioning for patient history, such as have you been experiencing any symptoms lately, or what is your concern today, to gauge a focus point for the examination. Information gathered should also be indirect, such as their appearance, behavior, and alertness, while also direct, such as asking about the patient's recent or current mood, and thought process and rationale behind it. Together, these observations can form a rough mental status assessment, and should take precedence towards mental health due to the aforementioned risk factors of mental illness with this population. Whilst this is happening, health professionals should already be taking note of the relative level of consciousness via the Glasgow Coma Scale method, scoring eye-opening, verbal response, and finishing with motor response later within the examination. GCS scores is an incredibly good screening tool for brain injuries, as even with mild injuries, patients with GCS greater than 13 have a 29% chance of operable intracranial bleed. CET imaging requirements for more advanced inspection of the brain require GCS scores that persist with less than 15 over 2 hours post-injury, an important consideration in real settings. In conjunction with these observations, medical professionals should be looking for pertinent negatives early on, such as the denial of headaches or absence of slurred speech, as critical indicators of patient health. One crucial factor is the pupillary reaction, in which pupils dilate in response to light, anxiety, drug use, and pain via the pathways of the sympathetic and parasympathetic responses. Any change of pupil response can be indications of raised intracranial pressure or lesion, so its significance should not be underestimated. Pinpoint pupils can indicate opioid overdoses or brainstem cerebrovascular accidents, whereas dilated pupils can be produced from anticholinergic drug overdoses or cerebral vascular accidents of the brainstem. Such observations are of clinical significance due to the associated risk factors of drug use within the mining sector. Complete the pupillary assessment by assessing the direct light reflex, and repeat by assessing the consensual light reflex of the eye not exposed to light. Assess pupil size, shape, symmetry, and the speed of restriction. The next part of the neurological exam is the assessment of the cranial nerves. Cranial nerve 1, olfactory nerve, can simply be assessed by the testing of various smells such as coffee beans or cinnamon. Bilateral loss of smell within the nostrils can usually point towards rhinitis or smoking, whereas unilateral indicates nerve lesions or deviated septums. Cranial nerves 2, the optic nerve, in which visual acuity of the person can be observed by a Snell chart or otherwise a crude reference point used like a newspaper headline or fine print. Visual fields can also be tested for visual field cuts, known as perceived holes in vision, and examined crudely via peripheral vision tests. Disturbances of vision could be unilateral, indicative of compression of the optic nerve, or even present with bitemporal hemiplegia, evident of partial blindness on the outer half of the both visual fields due to optic chiasm insults. Cranial nerves 3, 4, and 6 can be examined via elevation, pupil directed upwards, depression, pupil directed downwards, abduction, pupil directed laterally, abduction, pupil directed medially, extorsion, top of the eye rotating away from the nose, and intorsion, top of the eye rotating towards the nose. Isolated lesions of these nerves or muscles itself can adversely affect extraocular movement, where patients report diplopia and respond with a head tilt that attempts to correct vision or closing of the abnormal eye. Cranial nerve 5 can be assessed by touching the 3 major sensory branches with a sharp instrument: ophthalmic, maxillary, and mandibular branches. The motor aspect of the nerve can be examined both by the temporalis muscles and masseter muscles. Dysfunction of these neurons could be evident of lesions with cavernous sinus and can lead to asymmetry of the jaw on opening or weakness with mastification. Cranial nerve 7 requires inspection of the facial asymmetry and involuntary movements. Innervation of the facial nerve follows a specific pattern which allows health professionals to narrow anatomical origins of dysfunction. Both the right and left upper motor neurons innervate both the lower left and right motor neurons of the forehead. However, motor neurons of the face can only be innervated by the upper neurons from the opposite side. For example, a patient with a lesion with the right upper motor neurons would demonstrate the ability to frown on both sides of the face, however would be unable to close their left eye or raise the corner of their left mouth efficiently. Facial nerve is also responsible for taste sensation, however, is rarely of clinical significance. The vestibular cochlear nerve can be easily but crudely examined via simple phrases, asking the patient to repeat the perceived sound after each ear. Its significance and dysfunction, however, can be evident of an acoustic neuroma, a benign intracranial tumor. Cranial nerves 9 and 10 encompass the glossopharyngeal and vagus nerves, respectively, and are responsible for raising soft palate and gag reflex. Abnormalities of such pathways can be observed, such as the right glossopharyngeal nerve, resulting in uvular divergence to the left and vice versa. The vagus nerve specifically innervates the motor neurons of the pharynx and can be assessed by the patient's ability to speak and swallow. Cranial nerve 11, the spinal accessory nerve, innervates muscles for shrugging of the trapezius and sternocleidomastoid muscles, with dysfunction early observed by its affected side. Lastly, the hypoglossal nerve can be attributed to motor innervation of the tongue. Failure in the left hypoglossal nerve is evident of the tongue that deviates to the left. This phenomenon occurs when the normal functioning right side will dominate, as this no longer has opposition from its left. Other sensory tests on the extremities can be examined on the 2 afferent pathways, spinothalamics and the dorsal columns. Spinothalamics pathways are responsible for pain, temperature, and crude touch, whereas the dorsal columns are attributed to proprioception, vibration sensation, and light touch. Mining continues to be a dangerous activity, regardless of scale from large to small operations. These sites are still prone to worksite accidents, chronic stress from the job, suffering from a drug-dependent work culture on top of a populace already isolated from major healthcare services. Through in-depth training of advanced neurological assessments, health professionals may be able to appropriately screen these at-risk populations and improve patient outcome.